So good evening, everyone, and welcome to today's webinar on CKD symptoms and early detection. So we're delighted to have you here as we explore this important topic, and our goal is to provide valuable information on recognising CKD symptoms, understanding some of the risk factors, and highlighting why early detection is crucial for better management. So before we begin, I'd just like to cover a few housewarming items just to ensure that the session runs smoothly. So the first thing we're going to ask is if you could kindly keep your microphones muted throughout the presentation. This will just help minimise any background noise and ensure that everyone can hear the speakers clearly. There will be a chance for you to ask any questions at the end. And the chat box function, we won't be using that tonight, just so you're aware. But if you do have any questions, please just note them down, and then at the end, you can have an opportunity to share those with us. So just to take a quick look at what we'll be covering today, we'll be looking at the symptoms of chronic kidney disease, just going over a few common signs and symptoms that may indicate CKD, many of which can be really overlooked in early stages. We'll be looking at the risk factors, and we'll explore the risk factors that may make certain populations more susceptible to CKD. The importance of early detection, why early diagnosis of CKD is so crucial to better health outcomes, and how you can take the steps to detect it early. And then lastly, we'll be having a patient perspective from two of our ambassadors who will be sharing their personal journey with CKD. So let me introduce you now to today's first speaker, which is Dr. Alexa Wonnacott. And thank you again for joining us. So without further ado, Alexa, it's on to you.
Thanks very much. Good evening, everybody. I thought before we start talking about chronic kidney disease, we should just remind ourselves what the kidneys do in health. So I think if you ask most people what the job of the kidneys are, they'll tell you that it's to take waste out of the blood and to turn it into urine, and that's absolutely correct. So the kidneys filter out those metabolic waste, and that waste can come from the food that we eat, but it can also come from some of the medicines that we might take, which is why it's really important for patients with CKD to always discuss new medications with their doctor or their pharmacist, because there's a chance that if the kidneys aren't working completely, then there may be that drug might hang around for a little bit longer. The other thing kidneys do is obviously maintain fluid balance in the body. So we're about 60% water, and having too much water or too little water could be bad news. So the kidneys help regulate that by controlling how much is lost in the urine or how much is held back and preserved in the bloodstream. So if we were bonkers enough to run a marathon through the desert, then our kidneys would receive signals to say we're getting a bit dehydrated, preserve water, and would then only make very small volumes of very concentrated urine, just enough to get rid of the waste products. And kidneys can also regulate blood pressure in the same way, because they're maintaining not just the fluid in the body, but the fluid within our blood vessels. So if you imagine the blood vessels to be a pipe, and the pressure inside those is essentially what our blood pressure is all about. And the kidneys can also control blood pressure by controlling how much sodium or salt we have in our bloodstream, or how much is lost in the urine, because we know that sodium, hangs on to fluid, which is why patients who have a high salt diet tend to have high blood pressure. But it's not just salt that the kidneys can regulate. They also regulate other minerals in body fluids, things like calcium, potassium, magnesium. And potassium is something in particular patients with advanced CKD may know a lot about. High levels of potassium can be dangerous, and the diseased kidney does have some difficulties getting rid of potassium in the urine. So these sorts of patients, if instructed by their doctor, may be following a low potassium diet for that reason in advanced kidney disease. And then these last three here, I think most people, if you ask them, would have absolutely no idea that the kidneys had anything to do with these functions. One is to activate vitamin D. So vitamin D we get, of course, from the sun, not so much of that in Wales, but we also thankfully can get it from our diet as well. But in order for it to do the job that it needs to do in the body to maintain healthy bones, it needs to be switched on, it needs to be activated. And there's two steps for that. One is in the liver, but one is in the kidneys. The kidneys also regulate the acid-base balance of our blood. Now, that sounds quite dramatic, doesn't it? But really, the cells that make up our body, they're a bit like Goldilocks. They don't like it too acidic. They don't like it too alkaline. They like it to be just right. So the kidneys help keep the pH of the blood within very, very fine limits, so that the working conditions of all of our cells of our body is just perfect. And it does that by getting rid of acidic molecules in the urine or holding back some sort of base molecules. And then finally, the kidneys are actually important in regulating red blood cell development. So the kidneys make a hormone called erythropoietin. We shorten that to EPO sometimes. And that EPO hormone will tell the bone marrow to make red blood cells. So patients with advanced kidney disease can have what we call renal anemia because of a bit of a deficiency of EPO. Okay, thank you. Next slide, please. So I've mentioned the term CKD, chronic kidney disease, quite a lot there, but let's have a think about what chronic kidney disease really is. So the first thing to say is that the term chronic in this context doesn't necessarily mean something that is bad or terrible. Now, I'm not sure whether this is a bit of a Welshism. I'm from South Wales, Newport myself, and I know that people of my parents' generation particularly will use the word chronic to mean something that's absolutely awful or hideous, you know, the weather was chronic. In this context, we're not talking about it like that. We're talking about it to refer to a period of time. So something that is chronic refers to something that is sustained over a period of time. So chronic kidney disease means an impairment of kidney function that lasts for at least 3 months. Now, you can have a transient upset in your kidney function, perhaps because you've had a dehydrating illness, diarrhea, vomiting or something, which then recovers. Now, that's not chronic kidney disease. That's something called acute kidney injury. And the term acute here and chronic refers to that duration of time, okay? But unfortunately, CKD is a progressive condition for many patients. How fast or how slow the kidney disease progresses can be quite individual, and it depends on a number of factors that we're going to touch upon in a moment. But CKD is staged in 5 stages, where CKD stage 1 is the least severe and CKD stage 5 is the most severe. That denotes kidney failure. And we determine what stage of kidney disease a patient has using something called the GFR, which stands for glomerular filtration rate. And basically, that is how fast your kidneys are able to filter the blood, the filtration rate, okay? Now, the normal GFR is about 90 to 100, which is quite convenient because what it means that we can say in the kidney clinic is we can say that it equates to more or less a percentage function. So instead of saying to a patient, well, you've got CKD stage 3A because your glomerular filtration rate is 50 mils per minute, which is mind-blowing, you can instead say, look, your kidneys are running at about 50% function of what they would be. And that's a lot easier for patients to kind of get their head around and understand. And that GFR, that calculation, comes from an equation that is taken from a blood test, a simple blood test, where it looks at your creatinine level. It plugs that creatinine level into an equation that takes into consideration the patient's age and the patient's sex. And then it churns out this GFR, eGFR, you may have heard it called. The E stands for estimated glomerular filtration rate, okay? And lots of our patients will track their eGFR and their blood results on their mobile phones via apps like Patient Knows Best, so they can see how fast or how slow their own kidney disease is progressing. Okay, next slide, please. But what about the causes of CKD? So by far and away, our number 1 cause of CKD is diabetes, okay? And that includes type 1 and type 2 diabetes. Statistically speaking, if you have type 1 diabetes, you're more likely to develop CKD in your lifetime. However, there are many, many, many more patients out there with type 2 diabetes. So the type 2 diabetics make up the vast proportion of this section of the pie, okay? The second common cause of CKD is high blood pressure, or sometimes we call that hypertension. And that's because high blood pressure can be really damaging to the delicate vessels, the little blood vessels that live within the kidneys, those little filters, those filtration units called glomeruli. There are, in that other section of the pie there would be things like renovascular disease. So general vascular disease, again, interruptions to the vascular blood supply. That can be because of smoking, poor diet, high cholesterol, etc. And then you'll notice that things like polycystic kidney disease, which is a genetic condition that's passed down from generation to generation, that makes up really quite a small section of the pie, doesn't it? And glomerular disease, so here we're referring to autoimmune conditions like glomerular nephritis. So this is where the immune system, for no particularly good reason, starts attacking the kidneys. Again, it makes up quite a small segment. But what's interesting is that for me as a nephrologist, we tend to see all of these patients in the specialist kidney clinic. And that's because they have rare conditions And it's also because they have conditions which might need specialist medications to, for example, switch off the immune system. Now, that's not to say that we don't see patients with diabetes and high blood pressure in the specialist kidney clinic. Of course we do, but we don't tend to see them until they've reached more advanced stages of kidney disease, so CKD stage 4, 5, which means that there's a lot of patients out there in those diabetes, high blood pressure, vascular disease groups with early CKD that are being managed in the community by their general practitioners, maybe their diabetic specialist nurses. Okay, next slide, please. But let's take a step back now and let's think about the people who are out there in the community that don't yet have CKD, but might be at risk of developing CKD in the future. And there's a couple of obvious ones on this diagram, aren't there? We know that the commonest causes are diabetes and high blood pressure and hypertension. And so it's obvious that they're going to be in there as high risk groups. Smoking, because of the links to vascular disease, you might expect to see that there. Obesity, the more we understand about how being overweight affects the body, the more we realize that it is implicated in virtually every chronic disease out there, and CKD is no exception. Heart disease is one that you may not necessarily have automatically associated with chronic kidney disease. And heart failure in particular, it can be a big problem. So heart failure refers to the fact that the heart is not pumping efficiently enough to get the blood around the system. And the kidneys, for the kidneys, you know, blood is like food. The kidneys need 180 litres of blood every day that there's going to filter in order for it to do its job properly. So if the main pump of the system, the heart, is not pumping efficiently, then the kidneys are going to not get enough blood and they're going to start underperforming as well. And so we get a condition called cardiorenal syndrome. And increasingly now, heart doctors and kidney doctors are working together to try and make things better for these patients and use specialist drugs that have become available in the last sort of 5 or 6 years to optimize both the heart and the kidney. And then we've got things like family history. Now, obviously, genetic conditions that are passed down from generation to generation, that is going to put you in a high risk group, of course. But don't forget that there are certain ethnic minority groups who are up to 5 times more likely to develop CKD for reasons that we don't fully understand, but we think it may be down to higher incidence of diabetes and hypertension, for example, in Black and Asian communities. But one of the most important things that we can do for patients who are at risk of CKD is a simple, easy, cheap screening test, which is just to check a sample of the patient's urine. And I shall tell you why. Next slide, please. What is it about the urine? What can the urine of a patient with CKD or at risk of CKD tell us? Well, quite a lot, actually. Now, first of all, volume, okay? How much urine is being produced can be important. So generally speaking, it depends on your size. The bigger you are, the more urine you will make. But generally speaking, we make about 1 litre to 2 litres of urine per day. If a patient is making significantly less than that, that might tell us that that patient is dehydrated, not drinking enough. At the other end of the spectrum, when patients have very advanced CKD, the kidneys may be failing to the point where they're not able to make urine as they would, and the urine output starts falling. And that could be a sign for us in the kidney clinic that these patients are approaching the need for things like dialysis and transplant. But let's bring it back to the patients who are at risk of CKD and screening. What does the urine tell us with these patients? Well, it tells us about things in the urine that just should not be there in a healthy patient. Things like blood and particularly protein, okay? So protein, and in particular, we're talking about a type of protein that's called albumin. Proteinuria or albuminuria are the terms that we use to describe the presence of protein albumin in the urine. That is really, really important because it might be the very, very earliest sign of kidney damage. And that is especially true in the diabetic population, but also the hypertensive and other causes of CKD. So it's vitally important that we do check the urine for protein because it gives us so much information about early changes and damage to the kidney. And this picture on the left here is a simple urine dipstick. Some of you may have seen these already. It's literally just a sort of a strip of card that gets dunked into a patient urine sample, and then there is a colour change that happens, and we can hold up that strip there next to the pot, and that tells us, roughly speaking, have we got protein, blood, ketones, glucose, white cells in the urine, things that shouldn't be there, are they present? And that is such an easy, cheap, simple test to do. What it doesn't do is tell us exactly how much protein is in the urine, and that can be important. It's a great test, but it's not very sensitive. So if we do detect that a patient has got protein, the next thing we need to do is send that sample off to the laboratory where we can get a proper quantification of the exact amount of protein that is present and chart that over time. That's really important. So it's a great screening test, but there's a follow-on where we send it off to the lab and get the true value. And that test is called the ACR, or the albumin creatinine ratio, which is a right old mouthful. And I wish it was just called something as simple as the healthy kidney urine test, because it would make it a lot easier to understand. But anyway, that's what it's called. Now, this picture on the right here is not a pint of lager. This is the urine of a patient who has a lot of protein in their urine. So patients who have lots and lots of protein, they notice that they have this sort of frothy layer when they pass urine. Now, unfortunately, this doesn't happen right in the early days when there's just a tiny amount of protein present. And I wish it did, because it would be such a good visual cue. I think if patients were seeing this, they think, hang on, something's not right here, and go and see their GP, wouldn't they? But this is actually quite a late sign of protein in the urine having this frothy appearance. Next slide, please. But how does that protein get there in the first place? And why does it matter so much? So to understand that, we need to go back to our idea of the kidneys working like giant sieves, basically. And actually what we have is, rather than the kidneys being one big sieve, they're actually millions and millions of little tiny sieves, and they're called glomeruli. And they're filtering our blood for us all the time. And what happens in kidney disease, particularly diabetes, which is the example we've shown here, but what happens in CKD is that the holes of the sieve get a bit bigger, okay, in damage. And that means that things that would usually be kept in the bloodstream and not escape out suddenly start seeping out and escaping. So in this larger picture here, you can see you've got the healthy kidney. So you've got blood coming in, and then it splits into this funny little circular area here. That's the glomerulus. That's the mini sieve. We've got millions of these in our kidneys. And you can see in this first picture that the waste products are coming out, those little blue dots. So the urea molecules, the waste is coming out, and that's going down into the urine. But the P's, the protein, those big white dots there, they're too big. So they stay within the blood vessels, and then out they go. But in diabetic kidney disease, this picture here over on the right, you can see how those holes in the sieve have got bigger. The glomerular filtration pores have got much bigger. So not only is the urea and the waste products being forced out and squeezed out through that filter, we're also starting to see the protein start to escape. And that is therefore going to start appearing in the urine. And that is what we can detect with our dipstick test, really early sensitive test. And it matters because patients who have a high albumin creatinine ratio, a high ACR, protein in the urine, are at an increased risk of CKD progression from CKD stage 2 to 3 to 4, and so on. But not just that, patients who have a high ACR are at an increased risk of cardiovascular events. And by that, I mean heart attacks, strokes, mini strokes, peripheral vascular disease. And that is really, really important for patients to understand, because I think many patients do not necessarily put CKD and cardiovascular disease together. They think they're two separate things. Patients who have CKD are at a higher risk of cardiovascular events, and that ACR test is a really, really sensitive marker that we can use to try and work out what risk these patients have. Next slide, please. So let's go back to how the diagnosis of CKD is made now that we know all of that. So if patients are in a high risk group for CKD, the GP should be checking kidney function blood test. That gives us our creatinine level. That will automatically get plugged into the GFR equation and give us, roughly speaking, our percentage function. But crucially, that's not the end of the story, because we also need that urine test for protein, for that ACR, albumin creatinine ratio, because we know that that is a very early, very sensitive marker. And you can have a situation where your kidney function blood test is still normal, but your ACR is raised. And that tells us there is some damage starting to accumulate. And if we have abnormalities in either of those tests that remain abnormal for over 3 months, that's your diagnosis of chronic kidney disease made. Next slide, please. So what would we do once a diagnosis of CKD is made? Well, it's a two-prong attack at this stage. We have to focus on preventing progression of CKD through those stages. But we also, of course, have to focus on reducing that cardiovascular risk. And we do that by making sure that patients are achieving good blood pressure, good diabetic control if they're diabetic, and also good lipid control, cholesterol control. And we can achieve pretty much all of those things to some extent via lifestyle changes. So making sure patients are following a healthy, balanced diet, exercising regularly, not smoking. But occasionally we will also need, and more often than not, if I'm honest, we will also need medicines to help us achieve those things. And we are starting to use now, as I say, in the last 5 or 6 years, there are new medications that are available that have been shown to protect the kidney and the heart at the same time, which is fantastic news for kidney patients. But that's not the end of the story. Once we've done all of those things, we've recognized CKD, we've made the lifestyle changes, and we've optimized the medications, the patient needs to be monitored regularly with blood tests, urine dipstick tests, and blood pressure to make sure things are staying on a nice even keel and we don't need to change any of those medications. Because early diagnosis and intervention really, really is critical in getting this right. Next slide, please. Right, so my last 2 slides, Kidney Wales just asked me to talk about some of the symptoms of CKD, which is ironic really, because the truth is there really are no symptoms of CKD, and not until the patient has really quite advanced CKD do we ever notice any symptoms. And we're talking sort of late CKD stage 4 and 5. And that is really, really quite difficult and creates a real problem when it comes to CKD screening and patients being aware that they even have any problem with their kidneys. And what I quite often say is there's no squeaky wheel symptom in CKD. So, if you're developing heart disease, you'll probably go to your GP because you're developing chest pain. If you're developing chronic lung disease, you'll go to your GP because you're breathless or you're coughing. You're developing CKD, you got nothing. All right. So unless you know that you're in a high risk group and you're presenting yourself and you're being regularly screened, it may be that this can go unchecked for a number of years. And unfortunately, we will often pick up patients in this situation. And what's so important to remember is that even when there are no symptoms, patients with CKD are still going to be at that higher risk of cardiovascular diseases, and that accounts for every stage of CKD, although it does get worse as the CKD progresses. And that is why it's so crucial that we get CKD screening and identification early. We get this right. Next slide, please. I think this is my last slide. And this is about the symptoms of advanced CKD, okay? So we've gone right to the other end of the spectrum now. So advanced CKD, these are patients who are going to be in the specialist renal clinic. And these are the sort of symptoms that we will be asking our patients with advanced CKD about that help us decide jointly with the patient whether it's time to start thinking about dialysis, transplant, etc. And they're things like nausea, vomiting, absolute exhaustion, loss of appetite. Sorry, that says appreciate. I don't know why that is. Loss of appetite, but also a metallic taste in the mouth. Lots of patients complain of. That's because of a urea buildup. Because the kidney can't perform that vital function of managing the fluid well, we start to see fluid getting in places it shouldn't be. So around the ankles, it can even be in the face, around the eyes in young patients. Bubbling of the urine, we've already talked about, sign of damage to the little tiny sieves there, letting the protein through. Itching is a massive problem for our patients, especially on dialysis as well. And that's a sign of the buildup of toxins that the kidneys aren't clearing properly, starting to cause irritation and itch. Shortness of breath can happen. Again, this is down to fluid being in the wrong place. Fluid can be so troublesome that it can actually end up on the lungs. And sleeping difficulties, very, very common, particularly things like restless legs and cramping as well. So these are the sort of symptoms that advanced CKD might get, which you aren't going to miss. But the point of this is that by the time we are here with CKD stage 5, we've missed many, many years, maybe even decades of opportunity to slow down kidney disease and prevent that patient from even getting to the point of needing dialysis. And that's what we've really got to work on as a kidney community together, I think. So that's it from me. I'm going to hand over to Darren now, who's going to tell us a little bit about the perspective from the patient side of things. So thanks, Darren.
Hi, everybody. Thank you very much, Alexa. So my name is Darren. I'm a Kidney Wales ambassador. My journey started in 2016 with a new role at work. I noticed I was having some routine symptoms. I was feeling more tired. My ankle was swelling. I did have foamy urine at the time, but I didn't attribute it to anything. But at the time, I put it down to working in a busier role. I was busier all the time. I was on my feet more, working harder, and getting tired sort of associates with working harder in work. I let these symptoms build up for a couple of months until one day It was March the 5th, 2017. I woke up feeling very unusual. I felt very strange. My vision was all blurry. I was slurring with my speech. I was sort of feeling like out of body, kind of very unusual. So I ran NHS Direct and spoke to an advisor, and they sent me straight away to hospital. Um, they said the symptoms were very unusual and it sounded quite an emergency. So I got there and saw the triage and eventually saw the doctor. They were testing me for a TIA, which is a mini stroke, at the age of 36, which is not it's not a nice thing to have to go through, unfortunately. Um, they tested numerous things. I had a CT scan, I had blood pressure, cholesterol, blood tests, everything. Um, they couldn't see any lasting damage from a TIA, which is great, but my symptoms continued. I was referred to a cholesterol doctor and I was put on high blood pressure medication. Um, During another meeting with a TIA doctor, there was a junior doctor present who suggested they tested my urine so they could rule out CKD as part of why these symptoms are happening. So they listened to the junior doctor and then they found a protein leak, unfortunately, which is called nephrotic syndrome. I also had kidney damage as well. It was quite scary, to be fair. I mean, as I say, I was 36 years of age, that's, quite a young age to have a diagnosis of something quite as serious as kidney damage. So I was referred to a nephrologist in Morriston Hospital, and I was given a biopsy of my kidney, and I was diagnosed with something called focal segmental glomerulosclerosis, or FSGS for short, which is so much easier to say, thankfully, which means scarring on the kidneys. The glomeruli, as Alexa was saying just now, they're scarring to that, and they're obviously got permanently damaged. They don't fix once they're scarred; they're already scarred. The doctor told me that it was likely caused by high blood pressure, and something which I had from birth, which I never knew about, was familial cholesterolemia, which is high cholesterol from birth. It ran in my family, and so did the high blood pressure. Unbeknown to me, I was a smoker, and I like to. I wasn't a heavy drinker, but I like to go out on a night out. I like to eat, the takeaways and the fast foods and stuff, like most people in their 30s. It was nothing unusual for me to do that at that age. So after a meeting with the doctors, it was suggested that I take some blood pressure and cholesterol controlling tablets, statins, and to make some heavy lifestyle changes to give up cigarettes, cut down the salt in my diet. He said reducing sugar wouldn't do any harm at all. So I took that upon myself. I didn't even have a bar of chocolate or any form of chocolate or cake for 2 years. That's how determined I was to try and, help my condition. I increased my exercise levels. I cut down on fizzy drinks. I started drinking more water. Basically, just started looking after myself a whole lot better than what I was in the first place. I reduced my takeaways down to one a month. I was normally eating maybe two a week. So I completely canned it, basically. I wanted to look after myself and give myself a fighting chance against something I didn't know a great deal about, to be fair. I mean, there's not much awareness of kidney disease. I'll speak a little bit more about that in a moment, and I'll just continue about my journey. So after 6 or 7 years of hard work, really, reducing my blood pressure through medication and exercise and a better diet, I've reversed some of the damage, and my kidneys are in a much better position now than what they were initially. I've had no protein leak since around the end of 2022 or 2023. There's a minimal amount of protein in my urine now, which is exceptionally good for me. I feel a whole lot better in myself. I'm not as tired. I'm still having some symptoms occasionally, a little swelling, a little tiredness, some headaches from the blood pressure, but generally everything is managed. It's been managed very well. My doctor has said, it's unusual for someone to reverse that sort of damage and help themselves. Um, and not go into kidney failure straight from having a large protein leakage, which is what I did. But he said it's attributed to us catching it at the right time and the hard work that we've put in. It's not just me; it's my doctor and his colleagues as well. With the medications they give me, the advice they've given me, and the things I've learned myself as well. I like to read up on my condition and to try and help myself, and obviously help other people is something I like to do as well. So I've eliminated the majority of the issues, as I've said. I'm probably going to need more treatment in future, usually with the condition I have, FSGS, it can recur any time, unfortunately. But for now, I'm in some form of remission, which is really good for me. My journey is different to other people's, as obviously mine was caused by high blood pressure and cholesterol levels being high. There are other people with, different forms of kidney disease, different types of kidney disease, different reasons for getting it. But after the the diagnosis and everything, this is when I sought out Kidney Wales to, speak to other patients and get an understanding and everything. So I set up some social media pages on the same thing, just about my journey on kidney disease, the symptoms, things to look out for, etc., etc. I've worked alongside Kidney Wales for nearly 3 years now as an ambassador, and we've done some great things together, to be fair. I've I've got around 130 million views on my videos on social media, which is exceptional. A lot of the time you'll see me wearing a Kidney Wales t-shirt or sometimes a kidney research, to be fair. I love to help the entire community. It's everyone I like to help, and everything else. And Kidney Wales and Kidney Research work so closely together. Phenomenal, the partnership they've got. It's amazing, they're bringing the awareness out there for such brilliant, brilliant charities, brilliant people, It's something I'm very passionate about now as an individual, and something I'm passing on to my children as well with their diet, helping them create healthier food choices, for themselves, with eating fruit and vegetables and exercising, drinking more water and stuff. And they take it on board, and they ask, "Is this healthy to eat?" And I say, "Yeah, that's fine. You can have a nice banana. It's a good a fruit that helps you. It's got potassium in it. It's good for the heart and stuff. And the strawberries are good." And they're asking me, "Daddy, is this healthy?" And you say, "No, but it's okay. You can eat some chocolate in moderation." Everyone needs to know that these sort of things are, you know, eating so many things like too much sugar can be bad for you, but everything in moderation is fine. It's just a balance of everything. It's enjoy yourself, but keep an eye on, everything you need to keep an eye on, So that's my life for the moment. It's a busy thing, and helping Kidney Wales is a big part of my life. And I've been very privileged to work alongside Georgia and Ross and the other members of the team. I'm a very passionate kidney patient, and I really like to help other people. And I've had the privilege of meeting several of the other ambassadors, and it's just brilliant. So what I'm going to do now is I'm going to hand you over to Helen, another ambassador, speak all about her journey. Thank you very much, everyone, for listening. Thank you.
Thanks, Darren. Hi, everyone. My name is Helen Presty-Jones, and I've been a kidney patient for almost 30 years now. Can't believe it myself. Similar to Darren, I am a Kidney Wales ambassador. My story is that it started in 1995 when I was age 16. I was initially diagnosed with stage 5 renal failure. As Alexa was discussing earlier, is that I had chronic renal failure. So we think it started when I was born. We didn't know. But when I got to age 16, I started getting symptoms of being really tired. And when I say tired, it was literally, I went to school and slept. Those are the only two things that I did. And also I was really cold all the time. So the kind of cold you feel when you're coming down with flu is that bone achingly cold. Anyway, my parents took me to the GP, and that night I was taken straight away to Morrison Hospital, where I was diagnosed with stage 5 renal failure. Fortunately, my kidney issues weren't so bad that I needed dialysis straight away. And I managed to last 3 months without dialysis. But they got to that point when they went, "Helen, enough's enough. You need to start now." And I felt so much better for it, to be fair. One of the problems we had, because I was 16, and obviously, as a child, you're developing and lots of changes. It was very difficult for my parents to see what was normal in a child developing and growing up and what was different. Being really cold is like going, "Oh, maybe you are just susceptible to being really cold or being really tired. Maybe it was I'd done a lot in school that day." So to be fair to them, they found it really difficult to actually know what was different and what kidney issues were. There's so much more information out there now. We're talking 30 years down the line. There's huge amounts of information, and Kidney Wales and this this webinar is one of the sources of information available to you. Kidney Wales is a great source of information, as are the other charities that Darren has mentioned as well. When I was on dialysis, I suffered similar symptoms. I was still cold, I'm still tired, and I found that the cramps that you get, so a lot of people get like twitchy, a restless leg syndrome, that became worse as well. I also got really itchy skin. All symptoms of kidney failure and all kind of signs that that you go through. I found that it was better. I wanted to take control of the situation. I wanted to find ways that I could manage it myself, still being on dialysis, but to try and manage the symptoms as much as possible. So I have quite a positive mindset. So I looked at it in terms of, well, what can I do to help myself? So I made sure that wherever I went somewhere, I always had made sure I was kept as warm as possible. So things like take extra layers of clothing with you. I bought a nice thick fleece that was warm enough that I could, wear in a smart place or at home. Also, I had a hot water bottle with me most of the time as well to be able to keep as warm as possible. For the what was it? The itchy skin. I found that moisturizing didn't help. That didn't do anything for me whatsoever. And what I found is that I didn't like any material or anything touching my skin. So I found that wearing looser clothing was much better for me. Even to the point of instead of wearing pajamas, wearing pajama shorts instead, just so I had as little as possible against my skin. Also in that respect, things like you've got having some tracksuit bottoms to wear instead of jeans. I found that really helped me as well. I think it's really positive. It's really important to try and have a positive mindset and seeing what you can do. I appreciate a lot of the things that I've recommended there, the ways that I try to kind of manage the symptoms, can all cost money. And I appreciate that Kidney Wales, one of the outcomes that we support, one of the support functions of Kidney Wales is that they can support you with financial aid as well. So if you are having difficulty in managing the symptoms, that's something I really would recommend you approaching Kidney Wales about, and they potentially could help you with that. Right, I'll hand back to Georgia.
Amazing. Thank you so much for that. So before I start looking at some of the top tips that we as a group have sort of collected, I just wanted to say a big thank you to Alexa, Darren and Helen for all speaking today. And I just wanted to pick up on the last thing that Helen said there about the Kidney Wales financial assistance grants. So we are very proud to say that we are able to offer these to patients who may be suffering. And in the last 12 months, Kidney Wales has been able to support 48 financial assistance grants. We've managed to support 277 patients overall, whether that be with a wellbeing food voucher, a carers voucher. And so there are things out there that we can do to sort of support you. We do appreciate, as Alexa said, that sometimes these symptoms aren't being shown, or most of the time, sorry, these symptoms aren't coming into place until we're already at the stage where we need dialysis. So for someone who may be working 40 hours a week, suddenly being told that they need to start dialysis, and that takes up a large chunk of their time, can have a impact on them financially. And when you are struggling with a health condition, the last thing we want you to be worrying about is your finances on top of that. So if there is a way through these financial assistance grants where we were able to support, so like Helen said, that even if it's just something as simple as you get a wellbeing food voucher and then it means that you're able to get yourself something a bit more comfortable, it's something we're really happy that we're able to offer. So on from that, then we have got some top tips where I've been speaking to both Helen and Darren as well about what we would suggest looking at these symptoms and early detection. So one of the reoccurring things that came up is maintaining a healthy lifestyle. We are going to be hosting a diet and nutrition webinar on that shortly, so more information will come on that soon, and it will be on our website. As Alexa said, managing underlying health issues to help protect yourself from CKD, checking in with your GP if you have any concerns. Staying hydrated as well is very important, making sure that we're getting our kidneys working, and limiting alcohol intake as well was another one. So we did mention the start that we'd be having an opportunity for any Q&As. So if anybody does have any questions, please feel free just to turn your mic on, and either myself, Helen, Darren, or Alexa can answer. I am probably going to kick this off because I did have a quick question for Alexa. And that was, I noticed on one of the sites it said about anemia. Was that a symptom, or is that something that if you suffer with anemia, you were at risk of?
No, so anemia is something that patients with CKD might develop, but we don't tend to see that until patients are sort of towards CKD stage 4. It's because of that deficiency in that EPO hormone, that erythropoietin hormone, that patients will get, which means that their bone marrow just stops making red blood cells as efficiently. So it's a symptom of CKD, but you wouldn't describe that as a symptom, because people don't come in and say, I'm anemic. They come in and they say, oh, I'm absolutely shattered. Perhaps they'd be breathless. Perhaps they've noticed that they're quite pale. Sometimes ankle swelling can be a sign as well. So it's the classic thing, as Helen was saying, with CKD, is that you just get this sort of vague, I'm not quite right symptom, and anemia can be part of that as well. So again, it's blood tests that will let you know whether a patient is anemic. And if that patient is already known to have CKD, especially advanced CKD, they're probably under the kidney clinic anyway, in which case that's part of our regular monitoring, so that we can start the EPO injections, or we now have tablets that you can take 3 times a week, which again is quite new, and patients are loving that because that's avoiding a needle. So, you know, things are moving forward in CKD all the time, and that's just one example of how we're improving the care for patients with CKD. But that tends to be something that we would organise via the renal clinic. So it's not to say that if you are anemic, you're at risk of CKD. That's not the case. There are lots of reasons patients are anemic. But if you have CKD, you may develop anemia at some point in your CKD journey.
Amazing. Thank you so much for that. Does anybody else have any questions? It's okay if there's no more questions. That's must mean we covered everything. In which case, I just wanted to say thank you so much for watching. Thank you to our speakers today for being here with us, and providing that insight. And if you are concerned, please reach out to your GP. If you already have any underlying health conditions like diabetes, or high blood pressure, then again, speak to your consultant, have that conversation. They'll be very open with you. They'll be able to tell you what they're doing to monitor it. Alexa, please feel free to jump in and make sure I am saying this correctly. But if you have a consultant, they are able to tell you what they are doing to monitor the scenario, aren't they?
Yeah, absolutely. If you're under the renal clinic already, they'll be able to tell you what they're doing to prevent your CKD progression, but also what they're doing to manage your cardiovascular risk, which is really, really important. If you aren't with a kidney clinic just yet because your CKD is very early, or if you're in one of those high-risk groups, a diabetic patient who you know with high blood pressure being managed by the GP, for goodness sake, make a nuisance of yourself. Go to your GP, say, I would like my urine to be screened. Take them a sample of urine and say, here you go. Please dip this. I'd like to know if I've got protein, because I'd like to know if I've got CKD developing. Take the initiative. Do it yourself. GPs are really, really overstretched and really busy right now. So if you are worried and you know that you're in one of those high-risk groups, take that initiative and help yourself and go and get your urine checked, as a bare minimum, for sure.
Amazing. So thank you very much, everybody. And I'm just going to end the recording there. Thank you so much.